So I will speak about anatomically invasive endodontic procedures, because I like much more to call them anatomically rather than minimally invasive, because every procedure in endodontics must be related to the endodontic anatomy, to the anatomy and to the knowledge of the anatomy. So minimally invasive endodontic procedures must be always related to the anatomy, and how much minimally invasive we can be must be dictated and given by the original anatomy. Everything we do in our practice aims to overcome some technical limitations in our instruments and in our techniques. So always we are going to overcome these limitations, and technical evolution of endodontic instrument and techniques is leading to important changes in our clinical approach. So we, like Thomas Kuhn philosophy, we are going to shift our paradigms. So the scientific paradigm must be shifted from the original theory that we have to the new ones that are adapted to the new technologies that we have. And this is very important, to always have in our mind the possibility to follow a paradigm shift. Never remain focused on a paradigm just because it has been taught to us in the school, or we consider it such as a myth that cannot change, because everything changed in our life, and in endodontics is the same. Everything changed, and we must be ready to adapt our concepts to the new changes that we can have. Something that is fundamental is this golden rule, to preserve as much tooth structure as possible, because the prognosis of a survival rate of an endodontically treated tooth improves proportionally with the amount of sound tooth structure that we can maintain. So the trend of minimally invasive dentistry has been rising since some years to maintain as much tooth structure as possible, to go over this golden rule. And of course, endodontics will, and this following this trend also of minimally invasive dentistry. I have recently published a book that is called Minimally Invasive Approaches in Endodontic Practice, edited by Springer, and that is now available online. So you can online, and also you can find and order the hard copy of the book. So you can go to the Springer website with my name and the title of the book and find the characteristic, the chapter. So we will have a look in this lesson on these book chapters, how I have treated this topic with my co-authors, speaking about minimally invasive approaches, but anatomically based. And just a small mention, a short mention from where I came, that is Rome. That this is a painting that indicates that all roads lead to Rome. So I hope that you will follow this road to come to Rome and follow my concept of modern technology in minimally invasive endodontics.
Rome is a nice city, and everyone wants to visit.
I always I'm happy to welcome everyone who wants to come. They can contact me as soon as it will be possible again to travel around the world. I'm very happy when people come to Rome and to share some time with people around Rome and eating and having a walk around the city. So
yeah, thank you. But maybe because of the COVID-19 now, traveling is becoming very difficult.
Yeah.
Hopefully we can do as much as travel as possible.
I hope in the next future it will be much easier.
Yeah, hopefully.
So let's see which
Sorry
is
for interruption. Yeah, sorry for the interruption.
No problem. Let's see which is the role of the modern technologies in minimally invasive endodontics, because we have to say that we need special equipments and special techniques and special devices to perform a minimally invasive endodontics. First of all, probably we need at least a loop, if not a microscope. even if in some particular procedures we need a microscope, but we need magnification if we want to be minimally invasive, because we have to see and to have a look on, we have to see clearly what we are doing. And so we need magnification, because magnification permits us to see what we are doing in a better way, in a more clear way, in a clearer way. So everything we do is much better, much easier, much more conservative when we use magnification. And this will permit us to change our perspective on the treatment, because passing through naked eyes to the loops to the microscope, we can have a better vision of everything, both in the diagnosis and in the treatment. For example, this is a case of persistent pain after a first appointment after the retreatment, and we can see under the microscope clearly the crack, the micro crack, the vertical crack going through the wall of the canal in this mesial root. That was the cause of the persistent pain in this patient. If we didn't have the microscope to see it, probably we would continue to treat this tooth and we would have a failure, both clinical and with the patient satisfaction. So this is something very important. A second very important special equipment that we need is ultrasonic devices and ultrasonic tips. In this review of the literature, that's more than 10 years ago now, I already started to underline the importance of using ultrasonic device and ultrasonic tips. And with the microscope, if the loops is the perfect marriage, magnification and ultrasonics to work in detail in endodontics. In fact, it has been demonstrated that there were more canal detection when ultrasonic troughing was associated to an operative microscope. So in the case we want to be minimally invasive, we need to be sure that we are going to find any root canal. We have not to miss any root canal anatomy to be minimally invasive. And microscope and ultrasonics are the perfect marriage to find this balance. And in this video, it's clear why this is evident. If you use an handpiece with a burr, or you can insert the glass there, or you can insert the head of the handpiece. So you cannot have a good visibility there under the microscope and under magnification. While if you use an ultrasonic tip like this, you can have a better vision of what you are doing. You can have a better precision of what you are doing in searching all root canal anatomy. That is the most important step, not to miss root canal, to increase the prognosis of our treatments, because we know that missed anatomy is probably one of the most important cause of failure of our initial treatments. Another special equipment needed probably is a three-dimensional diagnostic tool like the CBCT. CBCT is very important in such difficult cases, or if we want to plan a minimal invasive case, because CBCT permits us to visualize three-dimensionally the root canal anatomy in 3 dimensions. So in the 3 different plans of the space, the relationship between the tooth with the surrounding structure and the lesion to the surrounding structure, for example, in this case with the mandibular canal. But above all, we can plan where the canal are placed, how many root canals we have, which are the inclination of the orifice, which are the curvatures that we have. So we can easily plan an access cavity, for example, more conservative, because we can have all the reference points, and we are sure that we know how many root canals we have and we do not miss any root canal. So this is a very important point. And these studies have demonstrated that the use of CBCT in detection of MB2 canal in connection with different type of access cavity have determined the fact that even in a small access cavity, we can visualize and identify all root canal orifices, because we already know before the instrumentation and before the root canal treatment. So my position is I do not do CBCT any single patient. I do not do CBCT just to plan an access cavity. But for example, if you have a preoperative CBCT for other reasons, for example, for implants or for a treatment plan in general, you can take an advantage of this CBCT to plan your endodontic treatment. For example, in identifying all the root canal, measuring the working length in a very precision way, having some 3D softwares to plan such treatments. For example, in this case, necrotic tooth but sound tooth with a periapical lesion, I had a preoperative CBCT, so I have planned the access cavity on the preoperative CBCT, and this is the superimposition of the plan and the access cavity opened, very precise. Just this was a simple case, but with this curvature, but just I was conservative at the occlusal surface, but the canal was very oval in the orifice, so we have to plan correctly to clean all these spaces. You can see this video how after the treatment I have cleaned this oval root canal, all the recesses, being in the same time conservative. And this is after the restoration, and this is the clinical image after the restoration, and the radiographs after 6 months. So another case in which I do CBCT, for example, in these cases is when I want to be conservative, like in this case, a mesial, a distal cavity. I wanted to perform a distal access cavity, maintaining this tooth structure of this patient because also from the malpositioning of the teeth. But in this case, I had no visibility. So I needed to understand if this lower incisor had 1 or 2 root canals, because we know that lower incisors may have 2 root canals. In this case, it was only 1 root canal, but I needed the confirmation by the CBCT. To perform minimally invasive dentistry and endodontics in particular, sometimes we need some adjunctive steps that normally I would not have done. So if you want to limit, for example, the CBCT, you have to open an access cavity more open, more larger, to visualize better any recesses, any root canal possible, the presence of any possible root canal. In this case, then it was done a simple, very conservative access cavity restoration. And going towards the minimally invasive approach, today there are also these guided access. I do not consider this technique a technique that you can use day by day on every single patient. It's not needed. When you have a standard anatomy, it's not needed. But if you have an anatomy like this, you can see this lower premolar with a periapical lesion, so necrotic pulp, but all calcification up to the apical third. In this case, sometimes, as in this case, I start with my microscope and my ultrasonic tips to find the root canal, because several times the root canal is not visible on the radiograph, but when you start tracking with your ultrasonics and the microscope, you can find it. But as soon as I do not find it, I do not insist risking to create a deviation or to create a perforation or to create a root damage. I stop, I ask for a CBCT, and on this CBCT, I will identify the apical part of the root canal in the CBCT, and I may plan the CBCT guided access cavity. And my good friend Antonietta Bordone, very specialist in this technique, in this case, have constructed me this guide for an endo access with a special burr that will reach through this hole the point in which the canal is visible inside the CBCT. So just you have to try the guide inside the mouth with the rubber dam to fix it with some resin composite, and then to trust in the 3D planning, to trust in your small burr that will reach then the point in which the canal is seen on the CBCT. So I put the rubber stop at this length, and I started to drill at mid-low speed with the handpiece to find this root canal, strictly trusting in this guy. And this is the point where I reached the rubber stop. When I inserted the burr, it was at this point, and I found at this point the root canal, with a little bit of deviation in the coronal portion, as you will see by the next final radiograph. But then I have prepared, instrumented, cleaned, filled the root canal, that with this very small burr that you can see at the end of the preparation doesn't increase the diameter so much. And so this is then the final X-rays and the 6 months radiographs of the healing. So this is a very nice possibility. Then you need performant root canal instrument to perform this approach. You need root canal instrument that are thermally treated, that are very flexible, prebendable, nickel titanium resistant to fatigue, resistant to torsion, to be inserted in such kind of minimally invasive access cavities. And this is something that you need to prepare safely your root canal treatment, your root canals. And you need advanced instruments and materials, because you need the most recent technology to prepare the root canal through these small accesses, to fill the root canals, and to create the conditions to clean them as much as possible, and to obtain the best results with the minimally invasive approach. And this is very important. So you need advanced filling materials and techniques, for example, to fill the root canals, being sure and safe that you are reaching the apical third, even in a known or small instrumented root canal. For example, the bioceramic sealers, together with a modified mild warm coronal compaction, may help us to fill the root canals in such cases, or in some cases in which you are minimally invasive. So we have to adapt our techniques, and most of all, the most important is we have to dedicate our time and our passion to these procedures. This is the most important special equipment that we need. Most important because to do this approach, we need to dedicate our time and our efforts. Because of course, to do better things, we must increase our efforts to do that. And this is very, very important. So probably the time of our treatments will increase by increasing the difficulties of our treatments, such as doing this minimally invasive approach. But we have to dedicate ourselves to this mission to obtain better results. We will see in the book that the vital pulp therapy is the first minimally invasive approach in endodontics, the first choice for minimally invasive approach in endodontics. The use of mineral oxide aggregate and bioactive endodontic cements is very important. As soon as we can maintain the pulp vitality with a correct diagnosis, we should perform, this should be the most minimally invasive endodontic treatment. So as soon as we can maintain the pulp vitality, even when we have a pulp exposure, but we are sure that we have vital pulp without an irreversible inflammation, we can clean it, perform the vital pulp therapy and the restoration, for example, in the same visit. And this is the 2-year controls, the 2-year radiographs, and the 2-year image of this control. We have also the 4 years clinical image of this control and the 4-year radiographs. So this is the first option to be minimally invasive. If you are not able to perform a direct pulp capping because there is an inflamed pulp in the coronal portion, The second option is to perform a partial pulpotomy. If you have an inflamed pulp here, you can proceed to remove this inflamed pulp, this irreversible inflamed pulp, up to the point in which you can obtain, you are able to find a non-inflamed pulp, and you are able to stop the bleeding and to create a blood clot up to which you can perform your vital pulp therapy. So the progression in this case is radar coronal to radicular, removing the bleeding pulp, sign of irreversible pulpitis, up to a point in which you are able to find a sound pulp. If you arrive to the orifice, you are doing a partial pulpotomy, a full chamber pulpotomy, like in this case, then repaired with the bioactive endodontic cements, so the bioceramic cements. And this is then the treatment we have done on this tooth, the direct restoration after this pulp capping or after this full pulpotomy. I also do not only endodontics, but all the restorative treatment, prosthetic treatment, adhesive aesthetic treatment of my patients. So I take care of all the treatment plans. So those are cases made by me with the shield technique for restoring the palatal shield of the tooth, and this is all the images for the coronal restoration of this case. And this is the lateral incisor after the restoration, and this is after the control after 1 month of this pulpotomy. Then you can perform the full chamber pulpotomy, for example, in molars. Like in this case, there was still bleeding after the removal of all the coronal pulp. So I was able to find sound non-bleeding pulp just at the orifice, and so I have performed a full pulpotomy with always these MTA-based materials. And this is the control radiograph immediately after, and the 1 year control and the 1 year radiograph of this case. Regenerative endodontic procedures are also very minimally invasive procedures. I have published some articles on this topic, and this is just one case that I have performed. With a periapical lesion, we can perform a calcium hydroxide medication in the second visit to promote bleeding and to perform to let the blood clot form, and to perform this regenerative procedure by using these bioactive endodontic cements to create this barrier protecting the blood clot. And you can see after 1 year and after 3 years, the root formation, the complete healing of the periapical lesion, and the developing of the root formation apical to this regenerative procedure. So let's always consider in your treatment the most minimally invasive procedures that are the vital pulp therapies. If vital pulp therapies cannot be done, of course, our fight starts from the access. So we have to maintain our minimally invasive approach in endodontics, starting from the access approach. So the access approach must start having our restoration in mind, because we must deal with the fact that we must be as much minimally invasive as possible, taking care of the possible restoration. So we have to overcome some myth present of a classic approach in cavity access, because we can classify the axis approach today in a traditional endodontic cavity, in a conservative endodontic cavity, or in a ninja or ultra conservative endodontic cavity. So we all know that the traditional endodontic cavity may be it's an old concept, because it aims to open such kind of very, very large cavities without any undercuts, with divergent parallel walls, with having a look on all the root canal orifice. But this is an old concept, classic concept of axis cavity preparation, that was linked with the opening of a predefined shape on our occlusal surface, And this was linked to the use of very, very limited files. So when we was using the stainless steel files, very rigid, we needed to open such kind of access cavity to permit the instrument to reach safely the apical third. That is not what we have now in our mind, because now something has changed. So now we have the possibility to be more conservative, and always in the middle it be the virtus, as it was and as it was said in the ancient time. So conservative access cavity, as based on this article by Clark and Kademi, is something that we want to follow this principle of conservative access cavity, but not with an extremization over than the ultra-conservative access cavity. Because the ultra-conservative access cavity, the ninja endodontic cavity, is an endodontic cavity that is an extremization that we can see on the social networks. So we want to make a difference between these three different access cavity, remaining in the middle, in the green one. The green one is the conservative one. The purple one is the traditional, and the red one is the ultra conservative. We don't need to be ultra conservative, because the studies says us that there is no influence passing from the red one to the green one in terms of fracture resistance of the teeth. So this is very, very important. But if we overextend our access cavities to the purple one, we can reduce the fracture strength. So we will be able to maintain our access cavity as much conservative as possible, avoiding to overextend them, but also avoiding to maintain them as an ultra-conservative cavity that does not make any sense, because it does not have any biomechanical advantages, and it has only some disadvantages. Because the major concern of the ninja access are that we can increase the instrument stress, the stress on the instruments, even if we have very, very performant instruments. We can reduce the cleaning, we can reduce the cleaning of the root canal. We can also complicate the obturation and restoration procedures while not having a real biomechanical advantage. That means that we may increase the risks, but not having a real biomechanical advantage, rather than performing a simple traditional, a simple conservative endodontic cavity. Because all the studies says us that we don't have these advantages. So my suggestion, like in this first premolar, always start small, but then you can enlarge from ultra-conservative ninja cavity to a conservative endodontic cavity. There is a difference between here from here. That is that everything is much simpler. You can have a better visibility. You can have a better, a more space to perform your treatment without reducing the resistance of this tooth. You can visualize all the root canal orifices, the isthmus. You can clean and fill all these spaces, obtaining such results and such control. So this is important. This is what I follow. Never use extremization in these concepts. Just follow the rule of the to have a good sense of everything, and follow these principles, the VA principles: vision and accessibility, visibility of the floor of the pulp chamber, not to miss anything, any root canal, And as soon as you have the visibility of the floor of the pulp chamber, you need to have the accessibility on the floor of the pulp chamber to treat everything that you have seen. And also you need accessibility to the roof of the pulp chamber to clean if you maintain some undercuts. So this is important, very, very important. So as soon as you don't have visibility, you have to increase a little bit your access cavity. So the access cavity is a dynamic concept, depending also on your skills and on the technologies that you have. So if you are able to see and to have a visibility and to recognize all the root canal anatomy, you can be as conservative as you need to have visibility and accessibility to that case. If you don't have, you need to enlarge a little bit more. For example, if you don't have loops, to see better, you have to enlarge more. Respect if you have the loops. So these are the concepts that I would like for you to follow. But minimal invasive endodontics is not only the access approach, is mainly related to the geometry of the root canal preparation. So it's mainly related to what we have called the pericervical dentin. So the dentin, 4 millimeter up and 4 millimeter below, above and 4 millimeter below the cemento enamel junction. Because we have seen that the enamel at the occlusal part is not so much important as the dentin that is surrounding the crestal bone. So the minimally invasive endodontics lay more on this area rather than the occlusal surface, because maintaining such kind of dentin here will improve the prognosis of your treatments, will improve the strength of your teeth. This is the golden area of your teeth, and you can clearly see when you have a failure. The fracture of endodontically treated teeth is always, or most, if not vertical root fracture, you have a fracture that is in this area, in the cervical area, in the area of the bone. So in the area where there is the level where you have the forces applied. And in fact, some articles, finite element analysis, have demonstrated that the stresses are concentrated on this area. And with the enlargement of the access cavity, the stresses in this area increase dramatically. So what is good is not to maintain the occlusal surface so strict. So you can perform an access cavity like a calla lily flower with an opening towards the occlusal surface, like in this case, with this shape, like an hourglass. So opening and removing the enamel in the occlusal surface with a bevel to permit a better visibility inside, to permit a better visibility, and to permit your instrument to do not have coronal interferences on the enamel because of their entrance parallel to the orifice. But then maintaining, as in this case of premolar with 3 root canals, maintaining this coronal preservation of pericervical dentin, because we know that, for example, the premolar always fractures in that area, while maintaining the apical anatomy. So you need the instruments to permit you this approach. This is very, very important. So what I suggest you is to do not follow anymore the myth of early coronal enlargement. So with the modern instruments, we don't need a preliminary indiscriminate removal of the coronal interferences that remove dentin in this area that is the most delicate. We want to choose an instrument, a root canal file, that permits us to be inserted in this anatomy, preserving this area and maintaining this dentin that increase the fracture strength of the tooth, with a dynamic removal of the coronal interference during root canal preparation, by using the same instrument for root canal that you are using for root canal preparation with a selective coronal enlargement. So using the same file that you are using for the root canal preparation, it will increase the selective coronal enlargement. It will maintain more dentin in this area to save your procedure, to be safer in your procedure. Always being safe in the apical preparation, in the apical anatomy. So never force the instrument, but enlarge only what it is needed to perform your treatment. If you need to enlarge more, you need to clean if you need to enlarge more to proceed apically, this should be something that you must do, depending on any clinical cases. So after root canal preparation and this concept in the book, we have treated also the importance of enhanced irrigation and the importance of the increase in improvement in debridement and disinfection in such minimally invasive preparation with a reduced taper of preparation, with a conservative preparation. So we need an irrigant activation, and we need adjunctive systems to increase and improve the chemical disinfection. We have a lot of systems for irrigant activation, you know, clearly, the manual activation, mechanical activation, the continuous activation, ultrasonic, sonic, or subsonic activation, apical negative pressure, laser activated irrigation, positive pressure devices. In my practice, always I use ultrasonic or high power sonic activation to perform such kind of activation of files of irrigant. Like in such case, you can see the irrigant moving up and down from the 3 root canals of this upper premolar. Always we need to activate this irrigant. This is an high power sonic device. This is the only sonic device that works well, such the ultrasonic devices. The other sonic devices doesn't have this power. But you can see this helps us to increase the cleaning and disinfection in the cases in which we are minimally invasive, in which we have restricted accesses, in which we have conservative root canal preparations. And then we can use also some adjunctive systems. There are different adjunctive systems for disinfection: the light activated disinfection, laser, nanoparticles, bioactive glasses, ozone, natural extracts. In my practice, I only use sometimes the light activated disinfection of this, but this is something in which we are going to have a lot of research, especially in the nanoparticles. So after irrigation, we need to have the obturation of the root canal systems, and we can have some obturation problems in minimally invasive approaches like this: interproximal access to save sound to structure while only removing the carious tissue, as you can see by the radiograph. We have to take care of instrumentation problems, so we have to choose the correct instrument, flexible, performant. Then we have to choose the correct techniques to activate our irrigants, to permit the irrigants to flow inside these minimally invasive prepared root canals. And then we have to choose an anatomically invasive obturation technique, because in several cases we are not able to reach the apical third with the pluggers in this case, or the carriers. So most of these cases in which we have a lower taper, I like to use a single cone and bioceramic sealer or a modified warm compaction of bioceramic sealers. Because in these cases, I'm not able to reach the apex with any plugger or any carrier because of the minimally invasive preparation of the access cavity and the minimally invasive shaping of these canals. Look at this case. It's another similar case. Look how much conservative I was. My performant instrument, my single cone and bioceramic technique, or mild warm compaction. And then for the restoration, also, I need to deal with some difficulties because we have restricted spaces, we have undercuts, we have to clean, and then we have to fill with our restorative procedure. So in our restorative procedure, we have always to deal with this problem also. So we have to take care about these undercuts to be sure that our adhesives goes there, to be sure that our composites goes there. So I like to use a flowable
Composite.
how can I say, the
Resin composite.
a flowable material with a bulk fill material, so that I can fill all the root canal orifice and the pulp chamber space, distribute this flow in the undercuts where I cannot arrive with my standard composites, and then I will reconstruct and build up all the rest of the tooth with the standard composites. So I like to use bulk fill, very flowable composite to go in the undercuts in these cases. And this is then all the steps of the restoration of this teeth. This is the final radiograph of this case. And then in the last chapter of the book, after the restoration chapter, you will also find a chapter on the possible alternatives to endodontic treatment, or to implant, or to extraction. So intentional replantation, surgical extrusion, tooth autotransplantation, they have a very good prognosis, and they may be considered very good survival rate, 90% of survival rate, and they may be considered intentional replantation, surgical extrusion, and tooth autotransplantation. They may be considered a really good, valid alternative to implant placement and tooth extraction. Such in this case, this was very deep caries lesion, missing tooth. So the treatment plan was to insert an implant here to substitute this failing bridge. And the patient was advised, we can insert 2 implants, extracting this second molar, or after extraction of the second molar, we can try, if it is intact, to treat it outside the mouth. And this was done with my associate, Nick. So to remove the apex there, to perform the filling of the retrograde filling of the cleaning and filling of the apex outside the mouth, and to reimplant the tooth in a most coronal position, so with a surgical extrusion, like in this case. So to treat the apex, to clean the caries, maximum extraoral time 12, maximum 15 minutes to obtain a good outcome, and then surgical extrusion, intentional replantation with surgical extrusion to expose the margin. Splint for a couple of weeks, orthograde endodontic treatment in a couple of weeks, up to the level of the retrograde filling, 2 weeks of splinting, and then after 3 months, when the implant was integrated, this was very well integrated, prosthetic procedures, 3 single crowns, and we have the time in the future to put an implant in this location, but now we still have the natural tooth. So all of this you will follow in the book, in this book, Minimally Invasive Endodontic Approaches, Minimally Invasive Approaches in Endodontic Practice, edited by Springer. And I want to leave you also with my last editorial project, that is my own education channel on the website, that is the Endo channel by Gianluca Plotino. You can find it on Facebook, on Instagram. Please follow the pages. You can find on endo-channel.com page. You will find a lot of educational materials there that you can follow, that you can see. And I think this is a very nice editorial project. There are already 4 lessons of 2 hours included in this channel. 2 lessons, the next 2 lessons will be online tomorrow, and the last 2 lessons of this year for 16 hours educational program will be online in the next month. So please follow this project, because this is really one of the most important project that I have done and I have realized this year. So thank you so much for your attention, and I hope it was interesting, and I hope this can be the beginning of a possible discussion on the topic that I have fastly showed you in this lecture.
Thank you, Prof. Plotino, for your interesting presentation and very comprehensive presentation. Really, you covered nearly everything from beginning to the end. But I have one question, if you don't mind.
Yes.
Which is, what is your position regarding full coverage crown for endodontically treated teeth, mainly on posterior teeth,
Yes.
to prevent fracture on the long term?
With these approaches, I am not doing anymore any single crown on sound teeth, even in the posterior teeth. It depends by the residual tooth structure. As soon as it has been demonstrated that as soon as you have the marginal ridge, you have you have the good resistance of that part of the tooth to do not perform a full crown. So as soon as if you have, for example, a missing marginal ridge, you can, my personal experience and the studies says that today we can perform a partial coverage restoration. That means the suggestion in posterior teeth is to cover with your restoration only the cusps near the marginal ridge lost, while maintaining all the tooth structure near the marginal ridge that remains. And so adhesive dentistry is going towards to guide this approach. Since the moment that we have a predictable adhesive dentistry, we can do this approach. For example, restoring endodontically treated teeth with adhesive partial coverage restoration. So I mostly use lithium disilicate onlays or overlays. So in primary treatments, I do not perform full crowns in 90% of the cases. I perform onlays or overlays. If I am missing two marginal ridges, I prepare a partial preparation with an overlay with a full coverage with adhesive restoration. A full crown I do only when I have to replace an already existing full crown, or if I have a very big missing tooth structure in which I need a ferrule effect and a crown that I perform only in few cases.
Yeah, thank you very much for your answer. Another thing, it is a clarification only, it is not a question. Regarding minimal invasive dentistry nowadays, is replacing the conventional dentistry, in which we have to conserve as much as possible of tooth tissues, starting from the conservative preparations for restorations only without approaching the pulp, into the indirect pulp capping, direct pulp capping, minimal preparation of the excess cavity towards to access the pulp chamber and orifices of the and canals of the tooth. Just a clarification. And if you don't mind, I'd like to speak a little bit in Arabic, just to clarify, to summarize what you have already said in your nice, interesting presentation.
Let me only say one thing before that. For me, it's impossible that these approaches will fully substitute the traditional approaches, because it depends by the skills of the operator and by the technology that you have. So for example, for students, it's always a step-by-step approach. You will start as a student, for example, by approaching endodontics with a more traditional in a more traditional way, and then as soon as you will increase your skills, you will acquire safety in what you do. You will have the possibility to have technology in your armamentarium. Then you will step by step increase your specialization in endodontics and follow this concept.
Of course, with the advances in dentistry and in technology nowadays, you are able to do the minimal invasive approaches, starting, as you already have mentioned, about magnification and ultrasonic techniques and irrigation, obturation, and so. So I'll summarize a little bit in Arabic, if you don't mind, for our listeners here in Syria. But before that, at the University of Sheffield, how we teach students at undergraduate level, we start with hand instrumentation, of course, respecting the minimal invasive, as you mentioned about Ninja. This is nice name, by the way. The minimal invasive by hand instrumentation at the beginning at year 2, then at year 3 and so on, they use rotary to save more time. But from the beginning, the teaching approach is to prepare or to remove as less as possible of sound tooth structure to increase the fracture resistance and the resilience of teeth. Yeah. أعزائي المستمعين في سوريا والوطن العربي، يسرنا أن حضر معنا اليوم الأستاذ الدكتور بلوتينو من جامعة روما. تحدث اليوم عن طريقة مختلفة أو الطرق الحديثة في معالجة الأسنان اللبية مع الأخذ بعين الاعتبار المحافظة على النسج السني السليمة قدر الإمكان. تحدث عن التغطية المباشرة، لم يتحدث عن التغطية غير المباشرة مع أنها تصنف ضمن طب الأسنان الحديثة الفائق المحافظة. تحدث عن التغطية المباشرة، عن استئصال اللب الجزئي، ومن ثم عن الاستئصال الكامل. أحب أن أركز على عدة نقاط وردت في محاضرته وهي لا تزال صالحة مع الأخذ بعين الاعتبار أن نحافظ على النسج السلمي السليم. أولاً يجب أن نحافظ على المدخل إلى الحفرة اللبية لإزالة ما تبقى من النسج اللبية داخل الحجرة اللبية، كذلك لأدواتنا كي تعبر إلى الأقنية اللبية بشكل مستقيم دون خطر الانكسار، وذلك باستخدام المواد أو المبارد والموسعات النايكل تيتانيوم، واستخدام مع وجود التكبير الماجنيفيكيشن اللي هو تحدث عن اللوبس النظارات الطبية أو الميكروسكوب، وكذلك تحدث عن استخدام التقنيات فوق الصوتية في التحضير، وبذلك نحصل على إزالة أقل النسج السنية السليمة، وكذلك التقنيات فوق الصوتية نستطيع أن نقوم بعملية الغسل والإرواء للأقنية، وكذلك أثناء حتى مفيدة أثناء حشي أو ملء الفراغ الناتج عن استئصال اللب. سألته سؤال عن موقفه ورأيه في التغطية الكاملة أو التاج الكامل للأسنان المعالجة لبيا وخاصة على الأسنان الخلفية. تحدث بشكل جميل وجيد بأن هذا هو الخيار الأخير بالنسبة إليه. في معظم الحالات هو لا يقوم بتطبيق التاج الكامل، مع أننا بالنسبة لي في جامعة شيفيلد لازلنا معظم الأسنان المعالجة لبيا الخلفية نقوم بتتويجها أو بتطبيق الحشوات أو الترميمات غير المباشرة إن كانت مصبوبة معدنية أو خزفية أو من الكومبوزيت. وأكرر ترحيبي وشكري. I would like to repeat my thanks and gratitude to Prof. Plotino, who gave us his precious time today to explore his chapter of his book. And I also recommend you to follow his channel as indicated on the screen here on Facebook and Instagram. Any question, Prof. Plotino, or any addition to your presentation?
I would like to thank you very much again for this opportunity, and just give my big hug, virtual hug, to everybody listening me, and to say everybody stay safe, and I hope to see you soon personally, as soon as possible. Thank you so much.
It is a pleasure. It is a pleasure to have you today, Prof. Plotino. And by my name and the University of Damascus and Prof. Osama Al-Jabban, the Dean of the Dental School here at the University of Damascus, we welcome you and thank you very much for your time and knowledge, shared knowledge. By the way, it is now well recognized that time and knowledge are the most important and precious thing we can share and give to others. Thank you very much.
Thank you so much.
If Prof. Osama Jabban wants to say anything.
Thank you. Thank you. Bye-bye.
Thank you very much.
Thank you. Thank you so much.
Hope to see you again, and maybe in Damascus.
Yes, I hope so. Everybody who wants to come in Rome in the future, I hope soon. Please, you have my contacts here, my email, and also any question or any doubt, you can contact me.
We can do definitely. We can do cooperation in the future between the University of Damascus and maybe the University of Sheffield as well, and you personally, Prof. Plotino. Thank you very much.
Yeah, pleasure. Thank you so much. Have a nice day.
Thank you. Bye bye.
Ciao.